welcome to our 217th webinar. Tonight, we have an interesting topic, rational use of oral cephalosporins in children, presented by none other than the esteemed Dr. Suhas Prabhu. Sir's name is a name synonymous with pediatrics in India, boasting over 45 years of experience. His expertise extends beyond clinical practice. He has held several prominent roles within the Indian medical community and gained international exposure focusing on pediatric infectious disease. Amongst his many accolades, Sir was most recently honored with the Lifetime Achievement Award by the Indian Academy of Pediatrics at Pedicon 2024 in appreciation and recognition of his exceptional contributions to the field of pediatrics. Sir, your commitment to medicine is truly inspiring, and we are very proud and fortunate to have you with us today. We can't wait much to gain all the knowledge you're going to give us tonight. So we welcome you and I request you to please take this forward.
Thank you, Dr. Sushma. My thanks to Dr. Chandramohan Asrani for allowing me to take this session, because this is something that I think I need to tell everybody. We are all confused with the plethora of antibiotics that are now available for oral use. And I know that while many children come directly to pediatricians, a lot of them must be going to family practitioners. And sometimes you are not sure as to what is the difference between the different cephalosporins that are available. So at the beginning, let me clarify that I'm not sitting somewhere in the Himalayas. This is an artificial background that Zoom now enables us and allows me to hide the untidiness of my home. So my talk is going to be today focused on oral cephalosporin, because that is what most of you are going to use. And I'm not really going to talk about injectable cephalosporins that would be used primarily for a patient who's admitted to a hospital. I hope today's session will be interesting to you and will help you to use the cephalosporins correctly depending on the proper indication so that your patient benefits. And very importantly, it will be a good thrust for increasing antimicrobial stewardship. We keep talking about this. We keep talking about the fact that we are having a lot of antimicrobial resistance now, and we need to use our antibiotics correctly and judiciously so that this doesn't get worse anymore. And in future, we will be able to use our antibiotics for treating infections rather than lose them because of development of resistance. So with this, I would like to start with my presentation. I hope, can you see my slides, Dr. Sushma?
Yes, sir, we can see.
Okay, fine. So the talk is really, as I titled here, rational use of oral cephalosporins in children. And I'm going to make it short. It has been announced as half an hour, and I hope I can finish in half an hour. So let's start with why we need to use antibiotics rationally. And as I just mentioned when I started my talk, that it is because we are worried about increasing antimicrobial resistance. And this has happened primarily because we have misused, abused, and overused antibiotics. We use them when it's not required. We've used the incorrect one, and we use them in the wrong doses and for long periods of time. And I know that everybody does it. It's not that I'm pointing fingers at you or anybody else. I know even pediatricians and consultants are sometimes not very clear as to why you use a particular antibiotic and how much and for how long. But because of this, as you see on this chart on the right-hand side, there's an increasing number of deaths that are occurring because of antimicrobial resistance, drug-resistant cases which cannot be treated by any antibiotics that are currently available. So as you can see, the purple bar on the left is the total. It's almost 50 million that is expected to die because of antimicrobial resistance worldwide in a few years from now. Sorry, this is in 2019, so it's already there. The orange bar that you see here is Asian region, Southeast Asia, and that's where, of course, India is. So we are a major contributor to this purple bar here, the orange bar here. What is the reason for this? The reason is because the organisms have developed methods of destroying the antibiotic by producing enzymes. And in case of cephalosporins, it's by enzyme called beta lactamases. And as you can see on this bar, this graph on the right, the number of beta lactams or beta lactamases that destroy beta lactams that bacteria are producing, we have identified almost 850 types now. So organisms are getting smart. They are able to produce more and more beta lactamases that can destroy antibiotics and prevent them from working. And why has this happened? This happened because they have been exposed to antibiotics. So because of exposure, the bacteria evolve to counter the antibiotics by producing beta lactamase. So if you have to reduce the ability of bacteria to produce beta lactamases, the only thing we have to do is use our antibiotics very sparingly and judiciously. That's the only way we can reverse the process. There's no other way we can tell the bacteria, oh, you need to stop doing this because you're getting resistant to the antibiotic that I'm using. Less exposure, less ability of the organism to mutate and produce a beta lactamase. So this, remember, this is rule number one. Rule number one is use cephalosporins very sparingly and judiciously. I would like you to remember these rules, because later on when I talk to you about cases, you will realize how to apply these rules to choose the correct antibiotic. Let's talk a little bit about cephalosporins. We've all forgotten the pharmacology. Briefly, cephalosporins are a large group of antibiotics. They are derived from the mold Acremonium, which previously was called Cephalosporium acremonium, and that's where the name comes from. They share a beta-lactam ring in the structure, in the chemical structure, along with penicillin. This is your beta-lactam ring. This square that you see here and this hexagonal ring, this is called as a beta-lactam ring. Both penicillins and cephalosporins act by blocking the synthesis of a chemical called peptidoglycan, which is an important constituent of bacterial wall cells. So the bacteria cannot make the cell wall and therefore they cannot multiply. So cephalosporins work against a very broad, large variety of pathogens. Of course, only those that have a cell wall. If they don't have a cell wall, like rickettsia and mycoplasma, beta-lactams won't work. Because they can prevent or damage the cell wall, they will generally kill the bacteria. So it's bactericidal. They are available, of course, as oral or parenteral, but of course, the rest of my talk is going to be only on the oral cephalosporins. They were discovered in 1945 by this gentleman, Giuseppe Brozzo, an Italian. And after they were discovered, the natural cephalosporin was chemically modified or structurally improved to make it more effective against a wider range of bacteria. Each time the structure was substantially changed, we got a new generation of cephalosporins. And now we have 5 of them in all. So we have first generation, second, third, fourth, and fifth generation. So each succeeding generation has a broader spectrum. So one rule for using antibiotics rationally is to use a very focused drug. Use a drug that will kill only the pathogen and have no effect on other organisms that are not really involved in this picture. So if we have to conduct Operation Sindoor, we have to attack only Pakistan. Don't try to use a broad spectrum nuclear bomb that will destroy Pakistan, Afghanistan, and all the neighboring countries. So we requires focus. So obviously, since the lower generation has a narrower spectrum, we have to use a lower generation cephalosporin wherever possible. That is, if you have an option of using first and third generation, use the first generation. If you have an option of using second versus third generation, use the second one. So this is rule number 2. Use the lower generation cephalosporin wherever possible. Now let's come finally to the oral cephalosporins. What are they? We have cefalexin and cefadroxil, which are first generation. We have cefuroxime, cefaclor, and cefprozil, which are second generation. And we have cefdinir, cefpodoxime, and cefixime, which are third generation. Okay, so let's go ahead now. What are the spectrum of these antibiotics? First generations will cover gram-positive aerobes, that is your methicillin sensitive Staph aureus, streptococci of all kinds, Streptococcus group A, B, D, Strep viridans, and 1 gram negative organism alone. It otherwise covers only gram positive aerobes, and that is E. coli. E. coli is 1 gram negative organism that is covered by a first generation cephalosporin. No other gram-negative organism is covered. And therefore, using cephalexin or cefadroxil for a fever like typhoid or a dysentery where you have gram-negative organisms other than E. coli is absolutely useless. Second generation covers all that the first generation covers, but also covers H. flu and moraxella, which I think you know are gram-negative organisms, but they are the ones that attack the respiratory tract, not the GI tract. So therefore, they are useful in a broader spectrum for respiratory infections. We'll come to that a little later. The third generation ones are divided into two types. One that primarily cover gram-positive organisms, that is your cefodoxime and cefdinir. They cover, of course, all the ones that are covered by first and second generation. And these, the cefodoxime and cefdinir also have some coverage of other gram-negative organisms besides H. flu and moraxella, but that's a poor coverage. If you really want to cover gram-negative organisms with a third-generation cephalosporin, like from Enterobacteriaceae group, like Salmonella, Shigella, then you need a predominantly gram-negative third-generation cephalosporin like cefixime. So cefixime is a third-generation cephalosporin that primarily covers gram-negative. But the disadvantage here is that it is not very good for gram-positive aerobes. So trying to use cefixime for a sore throat or a respiratory infection like a sinusitis is useless because it has got primarily gram-negative coverage with Enterobacteriaceae group, and these organisms are not the one that cause upper respiratory tract infections. And finally, we have this cefixime with clavulinate, that is a combination of a cephalosporin with a beta-lactamase inhibitor. That is a chemical that stops the beta-lactamase from destroying the antibiotic. And this is useful for ESBL, that is extended spectrum beta-lactamase producing Escherichia coli, and also enables the cephalosporin to cover anaerobes. But otherwise, remember, oral cephalosporins besides this one do not cover anaerobic organisms. So if you're suspecting an anaerobic organism, like say a dental abscess, like say a severe colitis with anaerobic GI infection, or you have a subcutaneous infection which has got necrotizing soft tissue infection, which is likely to be with anaerobic organisms, cephalosporins are useless. So remember, this is rule number 3. Oral cephalosporins or even injectable cephalosporins for that matter, unless they're combined with a beta-lactamase inhibitor, do not cover anaerobic organisms. Okay, so we have these 3 rules now. One word about cephalosporin vis-a-vis penicillin, and then we're going to have one more rule. Both are beta-lactams. So they're effective against a large variety of gram-positive and gram-negative organisms. They are the backbone of therapy today. But because they are both beta-lactams, and here you can see the structure, there is a similarity in the structure of penicillins and cephalosporin. This is that beta-lactam ring. So they are both beta-lactams. So they are both destroyed by beta-lactamate produced by or pathogens. But unlike penicillins, all cephalosporins are resistant to first-generation beta-lactams, including the beta-lactamase called penicillinase, which is produced by sensitive staphylococcus, and in fact produced by all staphylococci, which is the reason why unless you have a specific anti-staphylococcal penicillin, penicillins don't work for staphylococcal infection. So ampicillin, amoxicillin don't work for staphylococcus. Either you have to combine them with the beta-lactamase or you have to use a specific anti-staphylococcal penicillins such as cloxacillin, dicloxacillin, flucloxacillin, which are not easily available if you want to cover staphylococcus, even the methicillin sensitive staph aureus. But adding a beta-lactamase inhibitor can help to combat the next generation beta-lactamases produced by gram-negative organisms. Okay, so we know that some people are allergic to penicillin. And because there is a similar structure between penicillin and cephalosporin, Patients who are allergic to penicillin can have allergy to cephalosporin, but this overlap is only to the extent of about 10%. Majority of the patients are mild types of allergy. That means they have a kind of rash, or they may get oral lesions, or they may get diarrhea. Only a very small number, as is shown here, 0.04%, develop a type 1 hypersensitivity reaction, which can be severe and even anaphylaxis. The incidence of anaphylaxis is only 0.04%. Why am I telling you this? I'm telling you this that in the rest of the patients with penicillin allergy, cephalosporins become a very important fallback antibiotic. The patient is allergic to penicillin. I can't use any penicillin, but you can use a cephalosporin in 90% of patients. Only in 10% you can't use. So, generally speaking, when tolerated, you should use penicillin rather than a cephalosporin. So when you have a situation where a penicillin will work or a cephalosporin will work, unless the patient is allergic to penicillin, use a penicillin. Reserve the cephalosporin for patients who do not tolerate or have allergy to penicillin. So this is our rule number 4. Rule number 5 now. We cannot use, we should not use a cephalosporin when a penicillin will do the job. Okay, so with this now, I am going to take you to cases. We have the rules now. We just have to apply these rules and decide what oral cephalosporin we are going to use in these clinical scenarios. We have a 14-month-old baby who's returned from a visit to village, so he's traveled outside. He's come with a fever of 101.8 degrees Fahrenheit. The mother says the child is not feeding well, has vomited a couple of times. By evening, the child is irritable and now develops watery stool. And next day, the mother says the stools are now small, frequent, and bloody, with straining. The child is straining when passing stool. You can see, in fact, the specks of blood. I hope you can see that in this diaper here. So my question to you is, what is your diagnosis? I'm going to wait for 5 seconds so you can mentally think the answer. What is the answer? What is the diagnosis in this patient? I know this is not interactive, but I hope you have at least mentally thought of the answer. And the answer is a bacillary dysentery. This is a bacillary dysentery, where a classical clinical picture, you don't even need a stool test or a blood test or anything to make a diagnosis. This is a diagnosis you can make in your clinic. But anyway, the more important question, what antibiotic are you going to use in this patient? And I'm giving you 5 choices: ofloxacin, amoxiclav, cefixime, cefpodoxime, metronidazole. Again, I'm going to wait 10 seconds. I want you to think of the answer. Okay, you can put the answer in the chat box if you want. Otherwise, you can mentally think, because I'm now going to try and discuss why we should use a particular antibiotic in this patient. We have 5 choices, right? What about ofloxacin? But we know that the fluoroquinolones, of which ofloxacin is of course a fluoroquinolone, need to be avoided as far as possible in children below the age of 12. They are not licensed by the DCGI because of certain side effects that can happen. So ofloxacin cannot be a first choice. What about amoxiclav? It will probably cover the organism here. What are the organisms here? They're probably Shigella or E. coli, invasive E. coli, or Salmonella. So the amoxiclav will work in these patients. But remember, amoxiclav will also destroy anaerobic organisms, which are friendly organisms in your gut, which is not what we want. So therefore, amoxicillin should be avoided. Cefixime will cover the 3 common pathogens that I mentioned, that is E. coli, Salmonella, and Shigella. Most of them are not ESBL, and therefore cefixime will work. They are all gram-negative Enterobacteriaceae group. Cefpodoxime has more gram-positive coverage, whereas here we are talking about a gram-negative infection, so not a good choice. Metronidazole will work only for amoebiasis. This is a bacillary dysentery. Amoebic dysentery in this age group is very uncommon, and therefore there is no role for metronidazole. Therefore, even a combination of cefixime with metronidazole, or ofloxacin with metronidazole, or ciprofloxacin with metronidazole is not to be used. That is not rational. Nobody gets bacillary dysentery and amoebic dysentery at the same time. And therefore, the correct answer is cefixime. I hope this is clear. Let's go to the second case. We have a 3-year-old boy. He has got this rash under the chin that you can see. It's been going on for 3-4 days. It started as a small papule, but it is spreading. And you can see that there is a yellowish fluid oozing with some crust happening. And the child is complaining that it is painful. There is no fever or any systemic symptoms. And there are no illnesses in the recent past. So again, I'm going to wait 5 seconds. And you're going to think of what is the diagnosis in this patient. What would you label this as? What is the diagnosis? Because the first thing you must always do before writing an antibiotic is think what is the diagnosis. First step is what is the diagnosis? Second step is for this diagnosis, what are the pathogenic organisms? And then your third step comes as which antibiotic will work against the pathogens that are likely to be causing the infection in this patient. So this is, of course, a condition we call impetigo. Impetigo is a skin infection or pyoderma that affects only the superficial layers of the skin. The lesion looks very typical of impetigo, and we know that there is no systemic affection because I mentioned that there is no fever or any other systemic symptom. The child's appetite is good, he's eating well, only he has this local lesion. So this is impetigo. So now the next question. What should be our choice of antibiotic? I'm listing 5 now here: amoxicillin, amoxiclav, and of course we have our cephalosporins there: cefixime, cefpodoxime, cefadroxil, 3 choices, and we also have cloxacillin. So I'm going to wait again, and you're going to tell me, or at least you're going to think or write down in the chat box, what is your choice of antibiotic? Okay, let's discuss. Is amoxicillin a good choice? What are the organisms? Remember, that's the first question you ask. We know this is either Streptococcus or Staphylococcus. There are only 2 organisms, generally speaking, that cause impetigo. Amoxicillin, I just discussed a few minutes earlier, will not cover Staphylococcus because the Staphylococcus produces penicillinase, which destroys amoxicillin. Amoxiclav, yes, it will cover Staphylococcus because it got a beta-lactamase inhibitor, which acts against the penicillinase that the staph produces. But again, as I mentioned in the previous slide, it is got too broad a spectrum. It is overkill. It's going to destroy a lot of organisms, normal bowel flora and all. So this is not going to be my first choice. Cefixime, strep and staph are both gram positives. So why would you use cefixime, which is primarily gram negative? Cefpodoxime, yes, you can use it as gram positive coverage, but it also has gram negative coverage. So why use gram negative coverage when not required? Remember rule number 1, narrow spectrum. The lower the generation that you use, the better it is because the spectrum is narrow. And our first generation cefadroxil will do the job because it covers both Streptococcus and methicillin sensitive Staph aureus. What it will not cover is, of course, methicillin-resistant Staph aureus or MRSA, which fortunately is not common in the community unless the patient has recently been hospitalized. That's where it mostly comes from. Although we are seeing a few cases coming in the community, most of the cases that come from the community-acquired infections are methicillin-sensitive, and therefore cefadroxil will work. What about cloxacillin? Yes, cloxacillin will work, but it's not easily available. It needs to be given 4 times a day, and it's not palatable at all. It's quite bitter, and your child will not take it 4 times a day. So the correct answer in this patient is cefadroxil. First generation cephalosporin can be used. The thought may come to your mind, or you may ask me later or in the chat box, is why not use cephalexin? That's also a first generation cephalosporin. It covers strep and MSSA, but cephalexin needs to be given 4 times a day. Ask any mother whether she would prefer to use an antibiotic or a medicine 4 times a day or twice a day, and she will promptly say twice a day. And therefore, cefadroxil is preferable to cephalexin. Case number 3, 9-month-old child, formula fed by bottle. Mother says there's history of fever and nasal discharge for 3 days, but now suddenly since last night the child is crying excessively, is not feeding well. You examine the child, looks febrile, irritable, doesn't look breathless. The respiration is quiet. There are no chest signs, but there is a mucopurulent discharge. What is your diagnosis? 5 seconds again for you to give me a diagnosis. You can see the picture there, and you will see that only if you use an otoscope, and that gives you the diagnosis. The diagnosis is acute otitis media. You can see the bulging eardrum with pus in the middle ear. But of course, only if you do an otoscopy, you can find this picture, and that's diagnostic. Again, you don't need any tests. You don't need any blood count. You don't need any CT. You don't need any X-ray. This is a clinical diagnosis that you can do in your clinic. Okay, so we have a diagnosis. Next question. What antibiotic will you use? Amoxicillin, amoxiclav, cefixime, cefpodoxime, or azithromycin? 10 seconds again for you to give me an answer. Okay, let's analyze. Let's analyze. What is the choice of antibiotic in the case that I'm showing you on the left side? Would amoxicillin do? Again, the question to ask is, what is the likely organism? What organisms cause acute otitis media? Primary is Streptococcus. Next common is H. influenzae. Third common is Moraxella. I just described to you a few slides earlier that Moraxella and H. flu are gram negative. And you must also know that some, although not all, H. flu will produce beta lactamases and therefore destroy the penicillin. But the majority do not. Almost the incidence of beta lactamase producing H flu is maybe around 50% or less. So if you think, and this is a fact, that almost half the cases of otitis media are due to Streptococcus pneumoniae. Streptococcus pneumoniae is a gram-positive organism, so amoxicillin will work. Amoxicillin will also work for a large majority of H flu, all more than half of them, and therefore amoxicillin is likely to work in almost 3/4 to 80% of your patients with acute otitis media, and therefore it is a fairly good choice. It will cover all the possible organisms except some H flu that are beta lactamase producing. And for those, of course, you will have to use amoxiclav. But again, amoxiclav is an overkill. When amoxicillin will work, why use a beta lactamase? Because you're going to cause, I think I'm surely seen that. Amoxicillin is well tolerated by most children, but you give amoxiclav and 30-40% of them will come back to you with diarrhea because they've destroyed the normal flora. Cefixime, not good for gram positives. I just mentioned that strep pneumoniae is the commonest organism. 40% is caused by of otitis media is caused by strep pneumoniae. So cefixime won't work. Why use cefpodoxime when a penicillin is available? Remember rule number 3. So why use cefpodoxime here? Why use cefixime? Because not good for gram positive. Azithromycin or any other drug from that class, like clarithromycin, has very poor penetration in the middle ear fluid, unlike beta lactamases, and therefore the correct answer for this is amoxicillin. Can you use amoxiclav? Second choice, or in a patient who has not responded to amoxicillin, or in a patient who's coming repeatedly to you, you give him amoxicillin, and I think you know that otitis media can recur very frequently. एक महीने के बाद वापस आता है, फिर से कान में दर्द है और कान बह रहा है. So in those patients where repeated dose of amoxicillin have not worked, you can use amoxiclav. So again, this is not a patient where you're going to use a cephalosporin. 2-year-old child admitted for high fever for 3 days. He is breathless, retractions, saturations are 94% borderline. So obviously you're going to admit the child. High counts, neutrophilic predominance, CRP is very high. Ceftriaxone started. A pleural tap was done in this patient. You can see there's a bit of pleural effusion here in the corner. There's a pneumonia on the X-ray. And the pleural tap was sent for biofires, which is a molecular test which tests the DNA on the bacteria there, and they identified strep pyogenes. After 4 days, the patient is afebrile. The child is able to take orally, and the parents say, we want to go home. Now you are wondering, why is Dr. Prabhu talking about a patient who is admitted? Now I'm going to talk to you because this patient is going to go home. And the question now comes is, what is the oral antibiotic to give him? Anyway, what is the diagnosis? 5 seconds to think of the diagnosis. This is a community-acquired pneumonia. This is what we call a community-acquired pneumonia. The organisms are typically strep or H. influenzae in this age group for 2-year-old child. And this we have got a proof here because we have identified the organism by doing biofires. But anyway, the question now to you is, okay, usko ceftriaxone diya. Now he's going home. He's going to come to you and follow up with the general practitioner. What is your choice of antibiotic? And if the consultant who's discharging the patient has given the wrong antibiotic from this list, I want you to be empowered to tell me which is the correct one and call the consultant pediatrician and say, sir, why not use this one instead? So think of the correct antibiotic choice in this patient. Amoxicillin, amoxiclav, cefixime, cephalosporin, or cloxacillin. 10 seconds. Okay, let's see if we can analyze. Can we use amoxicillin? What is the organism? It's strep pyogenes. Does strep pyogen respond to a penicillin? Yes, it is an organism that will respond to even simple crystalline penicillin. It does not produce any beta-lactamase. It's a gram-positive organism. It has so far, by the grace of God, not developed resistance to any penicillin. So amoxicillin will be adequate for this patient. Amoxiclav, why use clavulinate? Clavulinate is a beta-lactamase inhibitor. Streptococci do not produce beta-lactamase. So therefore, they don't need a beta-lactamase inhibitor. Cefixime is a gram-negative antibiotic. Why use it for a gram-positive organism? Cephalosporin, yes, it will work. But remember rule number 3. When you have a choice between penicillin and cephalosporin, reserve the cephalosporin, prefer a penicillin. Cloxacillin, Streptococcus, we have identified is definitely strep. We are sure it's not staph. So why do we need cloxacillin? And as I mentioned earlier, not easily available, expensive, 4 times a day, difficult to give. Therefore, the correct answer is amoxicillin. So this is again a patient where you are not going to use an oral cephalosporin. You're going to use amoxicillin in this patient. Next case, 3-year-old girl, known case of vesico-ureteric reflux. She is grade 3. And she's on nitrofurantoin prophylaxis. She now comes with fever, vomiting, dysuria. You do a urine analysis, it shows pyuria, nitrite positive. And because she's vomiting and not able to tolerate oral drugs, you admit. Start on ceftriaxone. What's your diagnosis before we go to the future part? I think this is very easy. I'm going to reveal the diagnosis to you because we did a urine culture and it showed E. coli in a high colony count. Okay. Now, look at the culture sensitivity on this report on this patient. You can see it is resistant to ceftriaxone and cefuroxime, resistant to ciprofloxacin, resistant to cotrimoxazole, that is trimethoprim sulfamethoxazole, but susceptible to the other antibiotic. Now, this patient has been started on ceftriaxone, and after 2 days, she is well. The fever has gone. She is able to eat. They want to go home. What is the organism that is causing the infection? It is an ESBL E. coli. Why do we say ESBL? Because it is ceftriaxone resistant, cefuroxime resistant on the culture sensitivity report, but it is susceptible when it's combined with a beta-lactamase inhibitor. Okay. So, question now, what should be our antibiotic choice? We have 5 choices I'm giving you: amoxicillin, amoxiclav, cefixime, cefodoxime, or cefixime with clavulinate. 10 seconds. Time starts now. Okay, let's analyze. Can we use amoxicillin? It may possibly work because I just mentioned to you that E. coli can respond to amoxicillin unless they produce a beta-lactamase. Now, this organism is producing beta-lactamase. We have a blood report that says that. And yet I'm telling you that may possibly work. Why am I saying this? Just think it over for 5 seconds. Because we treated this patient with ceftriaxone without a beta-lactamase addition, and yet the patient responded. What happened here? What happened here is the fact that when the lab reports to you that some organism is resistant to an antibiotic, it is essentially talking about whether an antibiotic will work depending on blood levels that are achievable with the standard dose that is employed. When you use ceftriaxone, the standard dose, which you may or may not know is not really important, is 80 or 100 milligram per kg per day. You get a certain level in the blood, and when the lab tests the E. coli against this possible achievable blood level, it is resistant. But then it is resistant here, and yet this patient responded. How did it happen? It happened because beta-lactamases are excreted primarily in the urine via the kidney, and the levels of the drug in the urine are much, much higher. You can't imagine how much higher. It's so 20, 30 times higher than achievable in the blood. And therefore, when the lab says it is resistant, it may still work. And in this case, it has worked. The patient has responded. The fever has gone and the child's vomiting has stopped. And therefore, amoxicillin may work. Now, if you extend this to cefixime, it will also possibly work because ceftriaxone and cefixime have essentially the same spectrum. If the patient responded to ceftriaxone, he will respond to cefixime. Amoxiclav could be a choice, but again, you don't need the beta-lactamase here. You're tempted to use the beta-lactamase because it is supposed to be a beta-lactamase producer. But that is as per the lab report on achievable levels in the blood. In the urine, you probably don't need the beta-lactamase inhibitor. Cephalosporins not a good choice because it's primarily a gram-negative organism. Why use one that has gram-positive coverage? Cefixime clavulinate, again the clavulinate like the amoxiclav is unnecessary. So the correct choice in this patient is either amoxiclav or even cefixime will work, or even amoxicillin may work. Now let's come to the last case, 6-year-old boy, history of fall, followed by high fever, pain, swelling and tenderness in the lower thigh. He has neutrophilic leukocytosis on the blood and a CRP of 192 milligram percent. We look at the MRI which was done and you can clearly see that there is a collection under the periosteum. What is the diagnosis here? It is osteomyelitis. This patient was admitted, the pus was drained, it showed methicillin sensitive Staph aureus. Patient was started on injectable dicloxacillin. Given for 2 weeks, the patient is now afebrile, the CRP is down to 12 milligram percent. He's able to bear weight and walk. He's able to eat, there is no fever. Wants to go home. So the question now is, what is your antibiotic choice? The patient has responded to, remember, dicloxacillin. Antibiotic choices offered are amoxicillin, amoxiclav, cefadroxil, cefpodoxime, cloxacillin. 10 seconds for you to think what is the antibiotic that you would like to give to this patient, or what actually the orthopedic surgeon or the pediatrician should be advising on discharge. Okay, let's analyze. Can we use amoxicillin? The organism is Staph aureus. Methicillin sensitive, but it's Staph aureus. We know that Staph aureus produces penicillinase, and therefore amoxicillin is not going to work. It's not a good drug for Staph. Amoxiclav, yes, good drug for Staph, but again overkill because it's too broad spectrum. It has gram-negative coverage. It has anaerobic coverage. It's going to destroy your gut flora. Not a good choice. Will cefadroxil cover? Yes, it covers MSSA. Remember the slide I showed you that cefadroxil covers strep and also methicillin sensitive Staph aureus. So cefadroxil can work. Cefodoxime not needed because it has gram-negative coverage. And again, use a lower generation cephalosporin when there is a choice. So between these two, you will use cefadroxil rather than cefodoxime. Cloxacillin can be used, of course. This patient has responded to an injectable dicloxacillin. But again, I mentioned the reasons why we don't like to use cloxacillin because it's unpalatable, needs to be given 4 times a day, and is expensive. So what is the correct answer here? Cefadroxil. It will cover methicillin sensitive staph aureus, and you can complete the course with cefadroxil in this patient. So let's summarize now what we have learned from 6 cases and the initial theory. What role do cephalosporins play currently? Currently, the third generation cephalosporins are the workhorses for fighting infection. I think you know that whenever a patient gets admitted, generally speaking, he gets a third generation cephalosporin. This might be cefotaxime or ceftriaxone. They are very useful first line drugs for community acquired pneumonia. I'm talking about admitted patient. GI infections, say a typhoid fever or a gut infection, a peritonitis, bacterial sepsis, urinary tract infection, and even meningitis in children. This is a drug that we want to use first up. So, orally administered cephalosporins are useful in these conditions either for milder cases on an OPD basis, or as we saw in some examples in that I showed you, as a step down after discharge in patients who initially required injectable treatment in hospitalized. So once they go home, you can step down from these injectable ones to the oral ones. So these are the situations where we are going to use orally administered cephalosporins. What are the recommended use of oral cephalosporins today? First generation cephalexin or cefadroxil, uncomplicated skin and soft tissue infections. We saw the example of an impetigo. As a step down to oral in bone and joint infections as an alternative to anti-staph penicillins. In UTI prophylaxis, remember I said it works for E. coli, so we can use it as prophylaxis as an alternative to nitrofurantoin or trimethoprim sulfa because nitrofurantoin is not easily available as a syrup and is not palatable to take, and trimethoprim sulfa are not recommended in children below the age of 6 months because it can affect growth. Third generation gram-positive coverage, cefodoxime and cefdinir, as a step down to oral in respiratory infections like a pneumonia, but consider a penicillin alternative. As I said, if penicillin is available instead of a cephalosporin, use the penicillin instead. They can be used in resistant respiratory tract infections like sinusitis, otitis media, in patients where you cannot use a penicillin because the patient has a penicillin allergy, otherwise use a penicillin. Third generation cephalosporins, which have gram-negative coverage, that is cefixime, we use for UTIs, for common diarrheas and dysenteries, for typhoid fevers, and as a step down to oral after discharge in GI or abdominal infections, like a patient with, say, appendicitis, treated in the hospital, now you want to complete the treatment at home. A typhoid fever is now fit for discharge, complete the treatment at home because I think you need 14 days therapy. Nobody wants to stay in the hospital for 14 days to take injections. The third generation gram-negative with beta-lactamase coverage, that is your cefixime with clavulinate, is only for proven ESBL gram-negative infections that have responded to such a combination injectable in the hospital. If they have responded to a simple gram-negative third generation injectable like ceftriaxone without a beta-lactam addition, then you can go back to using cefixime like I showed you in that patient with UTI. What about second generation cephalosporin? I don't know where to use them. They are neither here nor there. बोलते हैं ना घर का ना घाट का. So I have hardly ever used a second generation oral cephalosporin in the last 10-15 years of my practice. Thank you. And I will welcome any questions.
Thank you, sir. So you said that you're not in Himalayas, but we felt you are there among, trying to on a mission actually that we doctors should use the antibiotics judiciously. Asrani sir always says that you're on that mission that we should be doing the right thing for the future. And so thank you especially for all the cases. Like we could see in the chat box that the thought processes were running, and especially the rationale behind, why and which antibiotic to use, which will not work on each of the different scenarios which you gave. I think there are few questions. One question earlier, someone had asked that how long to use the antibiotic in pneumonia, in
Yeah,
cases of
I
pneumonia.
saw that question when
Yes.
Dr. Prajakta has asked it. Dr.
Ye-
Prajakta, it will depend on how bad the pneumonia was and what was the organism. Two questions you need to answer. Most or pneumonias that are caused by staphylococcus will need a minimum of 3 weeks of antibiotics totally, parenteral plus oral, and some need as long as 6 weeks, particularly if there has been an empyema and an intercostal drain has been put or surgical treatment was required. We like to give up to 6 weeks, but a minimum would be 3 weeks for staphylococcus. If it's not staphylococcus, then if it's a neonate or a young infant, with a gram-negative pneumonia, again we give 3 weeks. But in other patients, you can give 10 to 14 days, especially if there has been no collection or empyema or pleural effusion. If there is a collection in the pleural space, we like to give at least 3 weeks. Otherwise, even 10 days might suffice. Or in an older child, even 7 days will work if the child has not been very sick to start with. Any other questions?
No, sir. Only I think Dr. Prajakta mentioned that please also suggest a dosage.
The dosage of which antibiotic?
I think probably she was referring to the same question. Dr. Prajakta, can you give a little more specific what you want to know?
I think you can refer in the book, ma'am. If I tell you orally now, you are unlikely to remember. And let me tell you, uh, even as a pediatric consultant, I would like to refer to the dosage of an antibiotic before giving, because many beta-lactam antibiotics in children have a range. For example, ampicillin can be given in a dose starting from 100 milligram per kg up to 300 milligram per kg. Amoxicillin can be given starting from 35 milligram per kg. Sorry, amoxiclav, 35 milligram per kg to 100 milligram per kg. So it depends on the organism. It depends on how sick your patient is, whether you're giving oral or parenteral. So always wise to consult a book. And I have edited a book called Rational Antibiotic Therapy. It is available from JP Publishers. I would recommend you buy that book. And at the end of that, there is an entire table of doses of all antibiotics that you can use in pediatrics, injectable as well as oral.
Thank you, sir. So there's one more question. Can we use ciprofloxacin in below 6 months of age?
Strictly speaking, you cannot use any fluoroquinolone below 12 years of age, leave alone 6 months. But if you have a bad sepsis and the child's life is at stake and you don't have any alternative choices, yes, we use fluoroquinolone. But otherwise, I would not use, just in case the child has any kind of allergic reaction or any kind of adverse action. If the patient takes you to the consumer court, the first question the judge will say is, why did you use a drug that is not licensed for children below the age of 12 when other options are available? Your only excuse is that there was no other option available in order to treat the infection in this child. I have used ciprofloxacin. So therefore, this is my answer. Don't use ciprofloxacin when anything else is available that can be used. There's a question about doxycycline. Again, the same issue of doxycycline. Should not use in children under the age of 7 unless there is no other option. Now, what are the cases where you use doxycycline in a child where there is no other option, even though the child is less than 7 years of age? Yes, there are indications. One example is classical is rickettsial infection. And rickettsial infection can be life-threatening. Remember, rickettsia don't have a cell wall. So no beta-lactam will work, no penicillin will work, no cephalosporin will work. And many of them are resistant to macrolides. So in such cases, yes, doxycycline would be a choice, even though the child may be just 3 or 4 years of age.
So then there is 6-month-old child with loose motions. How do you decide when and which antibiotic to start?
Which antibiotic I already told you in the case. But
Yes.
when to start is only when there is a dysentery. When you see actual blood in the stool, you see a lot of high fever, high counts, systemic toxicity. That's the only case where you use an antibiotic. Otherwise, the diarrhea, it might be severe enough to require hospitalization, severe enough to make the child dehydrated. It does not need antibiotic. It just needs a probiotic and needs zinc and needs oral dehydration or parenteral dehydration. And only if there is high fever, high counts, high CRP, and visible blood in the stool is when you use an antibiotic. Which antibiotic already discussed in the case, so I'm not going to talk about it again.
Right. There is, I think, similar question that below 2 years, which you have already answered.
The age is not important. I would use Cefixime was the first choice that I told in the case. I would use that even in any child above the age of 3 or 6 months. When the child is very young, below 3 months of age, we are worried whether he'll develop sepsis, and therefore such children you should not try oral antibiotic. You should give an injectable antibiotic and possibly hospitalize them when they are a neonate or below the age of 3 months. Above the age of 3 months, Cefixime would be your first choice for a bacillary dysentery, not for a watery diarrhea.
There's like there are combinations available for Cefixime Oflox 100. Is it rational?
Throw it in the gutter. Throw it in the gutter. Company may make and they will sell. I have never ever used it. I don't think any of us should ever use it after listening to my lecture.
So I think that was the last question. We have a lot of thank yous for you, and everyone has written they would like to hear you more. Thank you so much, sir. Thank you so much, sir, for this wonderful session today. We were really privileged to have you tonight.
Thank you for having me. Thank you.
Thank you, sir.